Hi, welcome back, students. Now, the topic which we are going to discuss is amniotic fluid and its disorders. That's a very, very interesting topic because although this topic has some facts related, some basic points related to amniotic fluid, which you do have to remember, but other than that, there is a lot of application, there is a lot of integration which is involved in this topic. And generally, you get a question, a clinical-based question on amniotic fluid. Right, so we are going to talk about amniotic fluid. We are going to talk about polyhydramnios, oligohydramnios, its causes and the risks related to poly and oligohydramnios and the management of oligo and polyhydramnios, right? So first, let's talk about some basic characteristics of amniotic fluid, which you will have to mug up. Number one is, what is the specific gravity of amniotic fluid? Specific gravity of amniotic fluid is between 1.008 to 1.010 and its osmolality is 260 milliosmoles per liter. Please remember that amniotic fluid is hypotonic in comparison to plasma. Whether we say maternal plasma or whether we say fetal plasma, it is hypotonic in relation to both of them, but it is isotonic to fetal urine. Now, the pH of amniotic fluid is between 7 to 7.5. Exactly, it is 7.2. And the application of this fact you are going to read in patients of premature rupture of membranes. See, most of the time in patients of premature rupture of membranes, they are going to tell you that there was a sudden gush of fluid which came out and their entire clothes were wet and there was fluid all over the place. But there are few people in whom the entire membranes do not rupture. There is a small little hole which is there in the membranes through which the amniotic fluid trickles. And that is when we get confused whether it is amniotic fluid coming out, whether it is, SUI, the urine which is coming out, or whether it is the vaginal discharge which is happening. And that is the time when this fact that pH of amniotic fluid is alkaline, right? It is near 7.2. It comes handy. Why? Because vaginal pH during pregnancy is very acidic. It is somewhere around 3.5. Right? So if I want to see whether it is a vaginal discharge, all of you know vagina doesn't have any glands of its own. Whatever discharge is coming from the cervix. So if the discharge, whichever is coming from vagina, if it has an acidic pH, we will do a litmus paper test and we will see whether the pH of that discharge is acidic or alkaline. If it is acidic, it is vaginal discharge. If it is alkaline, it is amniotic fluid. That means membranes have ruptured. So all the facts which I'm going to tell you over here, they will also have their own applications. It is not just mugging up of facts which is important. It is how to apply these facts into clinical questions, into your clinical applications, which is very, very important. Now, color of amniotic fluid. Basically, amniotic fluid is colorless. At term, it is turbid or cloudy, and it is straw colored. Also, amniotic fluid is odorless. Now, how are we going to apply this fact? Again, as I told you, that if you want to know whether it is amniotic fluid or urine, this fact is going to come handy to you because amniotic fluid is always odorless, right? Whereas urine has a typical odor. Right? Similarly, amniotic fluid, it will always be alkaline. Urine pH is a little acidic. Another very important thing is if you get a foul smelling liquor. So please remember that amniotic fluid is also called as liquor amni. Right? So if you are getting a foul smelling liquor that is characteristic of chorioamnionitis. Chorioamnionitis, right? So these are basic facts with their applications. Next, very important single liner question, straightforward question is about the volume of amniotic fluid. See, the volume of amniotic fluid at different gestational ages is different. As the gestational age increases, volume will increase. So you will see that at 10 weeks, the volume is 30 ml. At 12 weeks, it's 50 ml. 16 weeks, 200 ml. 20 weeks, 400 ml. You don't need to memorize this. What you need to know is that up till 34 weeks. So up till 34 weeks, I just want you to write this. Up till 34 weeks, the volume keeps on increasing, and at 34 weeks, the volume of amniotic fluid is 1000 ml, that is, it is 1 liter. Now, if 34 weeks is not given to you in the options, so if they ask you when is the maximum volume of amniotic fluid seen, the best answer to this question is 34 weeks of pregnancy. Now, if they ask you a range, then the range will be 32 to 34 weeks of pregnancy. Now, at 34 weeks, the volume of amniotic fluid is 1 liter. Then at term, that is at 40 weeks, from 1 liter, it is going to decrease and it is going to become 800 ml. And then the volume drastically decreases as pregnancy advances beyond 42 weeks. The volume of amniotic fluid drastically decreases such that at more than equal to 42 weeks, that is when it is a post-term pregnancy, volume remains just 200 ml. Right? So over here, you have to remember what is the volume of amniotic, when is the volume of amniotic fluid maximum? It is maximum at 34 weeks, range being 32 to 34 weeks. Then at that time, it is 1000 ml. At term, that is at 40 weeks, it is 800 ml. And then at 42 weeks, it decreases drastically and it becomes 200 ml. Now again, an application over here. This means that if I ask you, in case of post-term pregnancy, what are you going to get? So you are going to say that, ma'am, in case of post-term pregnancy, we are going to get decreased amniotic fluid, and that is what is called as oligohydramnios. So one of the reasons for oligohydramnios is a post-term pregnancy. Right? Okay. Next, what is the source of amniotic fluid? See, the source of amniotic fluid, basically there are some sources which you have to remember. There are many sources, but there are 3 of them which you will have to remember from your MCQ point of view. Number 1, in first trimester, the main contributor to amniotic fluid, it is a transudate of maternal plasma. And where is this maternal plasma present? It is present in the placenta and it has come through the spiral arteries, right? So it is a transudate of maternal plasma through the placenta, right? In the first trimester, that is the main source, right? Now, between 12 weeks to 20 weeks, the main source is fetal skin. Now, although over here at this time, see, all of you remember that urine production, it absolutely happens in a fetus by 12 weeks. By 12 weeks, 100% all the fetuses start producing urine. So between 12 weeks to 20 weeks, even fetal urine is contributing to the production of amniotic fluid. But then the main contributor between 12 to 20 weeks is fetal skin, right? And then after 20 weeks, there is keratinization of the fetal skin which happens. And because keratinization of fetal skin happens, now the main contributor beyond 20 weeks is fetal urine. So remember, fetal urine will never contribute to the formation of amniotic fluid at less than 12 weeks. Why? Because urine production in a fetus, it begins at 12 weeks, right? So this means that if I ask you that there is a fetus which has got oligohydramnios in first trimester. There is oligohydramnios in first trimester. Can it be due to renal defects? Can it be due to renal defects? Your answer is going to be no, because fetal urine doesn't contribute to amniotic fluid in first trimester, right? Fetus urine banana ही start करता है in at 12 weeks, right? So fetal urine is never a contributor to amniotic fluid before 12 weeks. Yes, after 12 weeks, fetal urine is a contributor. Is this clear to all of you? Yes. Now, so I have told you that basically there are 3 contributors. Number 1 contributor is maternal plasma in the image. Number 2 is fetal urine. and there is fetal skin. So there are three contributors: maternal plasma, fetal skin, and fetal urine. At different gestational ages, the main contributor varies. In first trimester, it is an ultrafiltrate from maternal plasma. Between 12 weeks to 20 weeks, it is fetal skin who's the main contributor. And then beyond 20 weeks, it's fetal urine. Now, if they simply ask you overall who's the main contributor for amniotic fluid, then overall, fetal urine is the main contributor. Overall, it's fetal urine undoubtedly. But fetal urine is never the contributor in first trimester. Clear to all of you? Yes. Now, a few more applied aspects related to it. Now, just now I told you that fetal skin is the main contributor up till 20 weeks. Why? Because after 20 weeks, keratinization of fetal skin happens. So one question if I ask you is, when does keratinization of skin exactly happens by? So exactly keratinization of fetal skin, it occurs by 22 to 25 weeks of pregnancy. That's exactly when keratinization is going to happen. Now, suppose if there is a defect in fetal skin, for example, there is a neural tube defect or there is omphalocele and gastroschisis. So because there is a defect in the fetal skin, skin is going to continue to produce amniotic fluid. It will continue to be a contributor of amniotic fluid. Normally, after 20 weeks, skin should not contribute to amniotic fluid. Why? Because of keratinization of skin. But suppose if there is a defect in the fetal skin, for example, neural tube defect or gastroschisis, omphalocele, which are abdominal wall defects, then the fetal skin will continue to contribute to amniotic fluid. And if fetal skin is continuing to contribute to amniotic fluid, then what is going to happen? The amniotic fluid is going to increase. Right? So when I'm going to talk to you about polyhydramnios, one of the reasons for polyhydramnios is neural tube defect, abdominal wall defects. Have you understood? Because in all these conditions, there is a fetal skin defect, and because of this defect, there is continuous transudation which is happening from fetal skin, and that leads to increase in amniotic fluid. Till here clear to all of you? Then, the third applied aspect of all these contributors is, just now I told you that the overall main contributor of amniotic fluid is fetal urine. So, if there is increased urine production by the fetus, which happens in case of maternal diabetes, which happens when there is multi-fetal pregnancy. So, whenever there will be increased production of fetal urine, there will be increase in amniotic fluid. Similarly, if there is a decrease in production of urine, for example, there is a kidney disease which is leading to decreased production of fetal urine. Like it could be renal agenesis, it could be any polycystic kidney disease. So if there is a disease which is involving the kidneys, then fetal kidneys, then the production of urine would be less and it will lead to decrease in amniotic fluid. Now, if you remember, in the video on teratogens, I told you there is a drug that is ACE inhibitors. What are ACE inhibitors going to do? ACE inhibitors, they decrease urine production. And because they decrease urine production, there is decreased amniotic fluid. So decreased urine production could be due to fetal kidney problems, or it could be due to certain drugs. Similarly, drugs like endomethacin, they decrease amniotic fluid because they decrease urine production. Right? So, whenever there is decreased urine production, which could be due to drugs like ACE inhibitors, which could be due to drugs like endomethacin, which could be due to a kidney problem, there will be decreased amniotic fluid. Have I made my point clear to all of you? Yes? Okay. Next application. Now, the one more contributor was maternal plasma. Right? And how was maternal plasma giving its contribution? It was giving its contribution via the placenta. right? Now, suppose if there is a big placenta. Now, whenever there will be a big placenta, what is going to happen? More maternal blood vessels are going to come into and open into the placenta. And when more maternal blood vessels are going to open into the placenta, there will be more transudation from maternal plasma. Right? So it is not transudate of maternal plasma. It is ultrafiltrate of maternal plasma. Sorry, please correct this. Right? So there will be more filtration from maternal plasma. That is common sense. The bigger is the placenta, the thicker is the placenta, more blood vessels will be there and there will be increase in filtration. And when there will be a big placenta, so that means there will be increased filtration of maternal plasma and that is going to lead to increased amniotic fluid. Similarly, if there is a small placenta, small placenta, there will be decreased filtration of maternal plasma and that is going to lead to decrease in amniotic fluid. This is clear to all of you? Now, in the video on placenta, I told you what are the conditions in which placenta is big. I told you that placenta is big in multiple pregnancy, placenta is big in RH incompatibility, and placenta is big in diabetic patients. Right? Now, one more thing which I want to point out here is that I think in the video on placentomegaly, I have said RH negative pregnancy. See, wherever we say RH negative pregnancy, we mean to say RH incompatibility. Right? Not a non-complicated RH negative pregnancy. Wherever we say RH negative pregnancy, we mean that if it is a case of RH incompatibility, that thing is going to happen. Right? So a big placenta is going to be seen in multiple pregnancy. It is going to be seen in RH incompatibility. It is seen in diabetes. So in all these conditions, you are going to get increased filtration of maternal plasma, and in all these conditions, there will be increase in amniotic fluid. Right? Similarly, whenever the placenta is small, and I told you placenta is small in case of uteroplacental insufficiency. Uteroplacental insufficiency happens in PIH and in IUGR. So whenever there will be a small placenta, the ultrafiltration is going to be less, the filtration is going to be less, and because of which there is going to be decrease in amniotic fluid. Right? So, have you understood the applications of these contributors of amniotic fluid? So, based on this, you can understand so many reasons, so many causes that why increased amniotic fluid is seen in RH incompatibility. Right? Why is there that in PIH you get decrease in amniotic fluid? Why is it that in neural tube defects or in abdominal wall defects you get increase in amniotic fluid? Clear? Okay. Then, see, fetus is not only producing amniotic fluid, fetus is also keeping amniotic fluid in balance by swallowing it. That is how fetus keeps amniotic fluid in balance. It produces amniotic fluid and it also swallows amniotic fluid. Now, again comes an applied aspect of this. The applied aspect is if there is a fetal swallowing defect, then what is going to happen? Now, if there is a fetal swallowing defect, fetus will keep on producing amniotic fluid that by the way of urine, but it will not be able to swallow it. Right? And if it will not be able to swallow it, there will be increase in amniotic fluid. Right? So, fetal swallowing defects can lead to increased amniotic fluid. Now, over here, I have given you a few datas which you can just write down just in case they ask you a single liner questions. Most of the times in your INI set exam, Central Institute exams, they do not ask you values. Right? Maybe in NEET, if they pick up some previous year paper, some old question, and they select a question from a very old Q banks, then they may give you questions directly related to values. So in that case, you should know the rate of production of amniotic fluid and the resorption of amniotic fluid. Right? Okay. Then comes the important points on composition of amniotic fluid. Please remember, amniotic fluid is 98 to 99% water. Now, what is the application of this? Because it is 98 to 99% water, it has no nutritional value for the fetus. It has no nutritional value for the fetus. So yes, amniotic fluid helps in distension of the uterus. So it gives space for the organs of the fetus to develop. It acts as a shock absorber. It helps in maintaining temperature. But then one function which it is not capable of performing is giving nutrition to the fetus, because it is 98 to 99% water. Now, in amniotic fluid, there are 3 hormones present: prolactin, renin, and insulin. So again, a theoretical question, that what are the hormones present in amniotic fluid? You should know these 3 hormones. Now coming to the abnormal colors of amniotic fluid. Just now I told you the color of amniotic fluid at term is it is straw colored and it may be a little turbid. But then if you are getting green colored amniotic fluid, then green color amniotic fluid means the fetus has passed meconium, and that is when there is fetal distress. When there is fetal distress, then the anal sphincters relax and meconium is passed by the fetus into amniotic fluid, and that because of this bile pigments which are present in the meconium, biliverdin, the color is green, right? Apart from that, suppose if your fetus is in transverse lie or in breech, then in these conditions, even if the fetus is not in fetal distress, right, if there is no fetal distress, still you may get a green colored amniotic fluid. And third is listeria infection. So green color amniotic fluid is seen in listeria infection. Golden color amniotic fluid, which is due to presence of pigment bilirubin, is seen whenever the fetus has got jaundice. And when has the fetus got jaundice? Fetus has got jaundice in case of RH incompatibility. Right? Tobacco juice or brown color amniotic fluid is seen in intrauterine demise of the fetus. Saffron color or yellowish green color amniotic fluid is seen in post-term pregnancy, and a dark red colored amniotic fluid is seen in case of concealed hemorrhage. Concealed hemorrhage. So I'm just repeating this table for you for all those who cannot see, and later on you are going to write a comment that ma'am, your handwriting was very small. Green color amniotic fluid is due to meconium, which is because of the presence of pigment biliverdin. It is seen in case of fetal distress, in transverse lie and breech, and in case of listeria infection. Golden color, which is due to presence of bilirubin, is seen whenever the fetus has jaundice, and fetal jaundice is seen in RH incompatibility. Tobacco juice or brown color is seen in intrauterine demise of the fetus. Saffron color or yellowish green color amniotic fluid is seen in case of post-term pregnancy, and a dark red color is seen in case of concealed hemorrhage. Which hemorrhage? Concealed abruptio placenta. Clear? Okay. Now, what is the investigation of choice to measure amniotic fluid? The investigation of choice to measure amniotic fluid is ultrasound. And on ultrasound, whenever I get a patient, a pregnant female, and I have to measure its amniotic fluid, arbitrarily I am going to divide her abdomen into 4 quadrants, in such a manner that linea nigra is going to mark the line which separates the left side of the abdomen from right side of the abdomen, right? So using linea nigra as the landmark, I'm going to divide the abdomen vertically into left and right parts. And then using umbilicus as the landmark, I am going to divide the abdomen into upper and lower quadrants. Right, so this is arbitrarily what I'm going to do. So I'm dividing the abdomen of the mother into 4 quadrants, and in each quadrant I am going to measure the amniotic fluid which is present in the form of pockets. So when you do an ultrasound, you will see that amniotic fluid is present in the form of a pocket. So if you see this ultrasound over here, so in this ultrasound, this is the amniotic fluid pocket. Now, in this amniotic fluid pocket, I am going to measure the largest diameter. The largest vertical pocket I am going to measure. Over here, this is the largest vertical pocket. This is the largest vertical pocket, and this is the largest vertical pocket. So largest diameter of the amniotic fluid, the largest length which you can measure in that particular pocket, you are going to take it. For examples over here, suppose these are the various organs, right? And amniotic fluid is visible in this part, right? So I am going to measure the largest vertical diameter like this, right? So now suppose in this quadrant, amniotic fluid is visible over here. So I am going to measure the largest diameter like this. So this was pocket A. I am measuring the largest vertical diameter. This is pocket B. I am measuring the largest vertical diameter. This over here is pocket C. I am going to measure the largest vertical diameter over here. Right? And suppose this is your pocket D. I'm going to measure the largest vertical diameter. So in each quadrant, you are going, see, amniotic fluid is going to appear in the form of pockets, right? So can you see this? Right? So this is what is amniotic fluid. Fluid is always going to appear black to you, right? So over here, you have to measure the largest vertical diameter. Please remember, you have to measure the vertical diameter. You don't have to measure transverse diameter. You are not going to measure the transverse diameter like this. No, this is wrong. You are going to measure the vertical diameter, the largest which you can measure, right? So what I am going to do, I am dividing arbitrarily the abdomen of the patient into 4 quadrants, and in each quadrant, amniotic fluid is going to appear in the form of a pocket, right? So in that pocket, I am going to see whichever largest diameter, vertical diameter I can take out. So you are going to add largest vertical diameter of each quadrant. And that is what is called as amniotic fluid index. So what is amniotic fluid index? Amniotic fluid index, how are you going to calculate? You should add the largest vertical diameter of amniotic fluid pocket in each quadrant. That is what is called as AFI or amniotic fluid index. Right? So it is the sum. If you have to define AFI, how are you going to define AFI? It is the sum of largest vertical diameter of the pocket of amniotic fluid in each quadrant. Right? Now, normally AFI level is between 5 to 24 centimeters. This is normal. So the normal AFI is 5 to 24 centimeters. If AFI levels are less than equal to 5, that is called as oligohydramnios. If AFI is more than equal to 25, it is polyhydramnios. Less than equal to 5, oligo. More than equal to 25, poly. Now, there is small variation over here in different literatures which we have, in different references which we have. Some of them say more than 24 becomes polyhydramnios. Some of them say 25 and more than 25 becomes polyhydramnios. Some say 24 and more than 24 is polyhydramnios. But some say 25 and more than 25 is polyhydramnios. So this small difference may be seen in different textbooks. But what you remember is, if amniotic fluid is between 5 to 24, it's generally taken as normal. The moment it becomes 25 or more than 25, that is polyhydramnios. If it is 5 and less than 5, then it is oligohydramnios. Clear to all of you? So this is what is amniotic fluid index. Now, Please remember, this method of reporting amniotic fluid in the form of amniotic fluid index, this is not the most sensitive method. This method cannot be used in twin pregnancies. Right? So then how am I going to estimate amniotic fluid in a twin pregnancy, and what is the most sensitive method? The most sensitive method is you measure the vertical diameter of the largest single pocket. Right? So out of all these 4 pockets of amniotic fluid which I am seeing, I will pick up which one is the largest. So over here, you can see that pocket C is the largest one. So I am going to measure the vertical diameter of pocket C from the image. Right? So from the image, in image, it is C. The hand-drawn image which I have made, it is pocket C. So I am going to measure the vertical diameter of the largest single pocket. Right? That is what is called as single largest vertical pocket, SVP. In short, you are going to write single largest vertical pocket or single deepest pocket. Single deepest pocket or single largest vertical pocket. The best parameter is single largest vertical pocket. What is the best parameter? Single largest vertical pocket. So normally the single largest vertical pocket, SVP, or single deepest pocket, normally it is between 2 to 8 centimeters. Vertical diameter is 2 to 8 centimeters. Now, if diameter becomes less than 2 centimeters, it is oligohydramnios. If it is more than 8 centimeters, it is polyhydramnios. So again, I'm repeating. Over here, I was doing in amniotic fluid index. I was dividing the pregnant female's abdomen into 4 quadrants. And in each quadrant, I was seeing that amniotic fluid is appearing in the form of pockets. So I was measuring the largest vertical diameter of each pocket, right? Of each quadrant. Of each quadrant, I was measuring the largest vertical diameter and then I was adding them. Right? But this is not the most sensitive method. Now, in the next method, what I'm doing, I am just seeing that which pocket is the largest pocket. So suppose over here, this pocket is the largest pocket. Right? So when I measure, I see, okay, this pocket is the largest vertical pocket. So now I'm going to just focus on that largest pocket and I am going to measure the vertical diameter of that pocket only. Whichever is appearing largest to me, I'm going to just measure the vertical diameter of that pocket. And that is what is called as single deepest pocket or a single vertical pocket. Right? And this is the most sensitive method of measuring amniotic fluid, and this is the method which you are going to use in twin pregnancy. So this method is used in twin pregnancy. AFI cannot be used in twin pregnancy. Single vertical pocket, normally it is the diameter of the single vertical pocket is 2 to 8 centimeters. If it is less than 2, it is oligo. If it is more than equal to 8, it is polyhydramnios. Remember, both oligo and polyhydramnios, if they are present, right? Oligo and polyhydramnios, whenever they are moderate or severe, that means that pregnancy is a high-risk pregnancy. Mild polyhydramnios, mild oligohydramnios, I'm okay with it. That pregnancy is not a high-risk pregnancy. But moderate or severe oligohydramnios or polyhydramnios means we are dealing with a high-risk pregnancy. And in all high-risk pregnancies, so please write that. moderate or severe oligohydramnios or polyhydramnios make pregnancy high risk. And in all high risk pregnancies, you should do fetal monitoring. You have to do fetal monitoring starting from 32 weeks of pregnancy, right? And in high risk pregnancies, you also have to go for induction of labor. You yourself are going to terminate the pregnancy. At what time? That depends upon different conditions. So in all high risk pregnancies, we have to go for fetal monitoring beginning at 32 weeks. What all am I going to do in fetal monitoring? I'll let you know. And in all high risk pregnancies, you will have to terminate pregnancy at a particular time. What time depends upon different conditions. So when I say you have to terminate pregnancy at a particular time, that means I'm going to initiate the process of labor at that particular time. In other words, I'm going to go for induction of labor. Right? That is a common thing about all high risk pregnancies. Right?